Hi everyone. Today I'm going to, my name is Shahir. I'm a physiotherapist in DPRC. Today we are going to, I'm going to speak about spinal cord injury and rehabilitation. So it's a vast topic. Within this time frame, we cannot do the detailed presentation. So I will just do a superficial view of about spinal cord injury and its rehabilitation. So, like we all know, spinal cord is a long, thin tubular structure made of nervous tissue, which extends from medulla oblongata in the brain stem to the lumbar region of the vertebral column. And brain and spinal cord together make up the central nervous system. The function of spinal cord mainly transmission of nerve signals from the motor cortex to the body and from the afferent fibers of the sensory neurons to the sensory cortex. It also a center for coordinating many reflexes and contains reflex arc that can independently control reflexes. And there are 31 pairs of spinal nerves arise from each segment of spinal cord. It innervates different parts of the body. There are 8 cervical segments, then 12 thoracic segments, and 5 lumbar segments, 5 sacral segments, and the last one is 1 coccygeal segment. Any injury to the spinal cord by any means, or like a direct trauma or indirect trauma or an infection, causes disruption of its functions in different parts of the body. Disruption of function in different part of body. And based on the clinical manifestation, the spinal cord injury is divided into 4 different syndromes: central cord syndrome, Brown-Sequard syndrome, anterior cord syndrome, and posterior cord syndromes. And there is also a different segmental level injury that is also we can see detail about that one. And first one is the central cord syndrome. Central cord syndrome most commonly caused by extension injury. The upper extremities mainly affected than lower extremities, distal more than the proximal muscles. So loss of motor function in the upper extremities, then incomplete loss of motor function on the trunk, and variable degree of sensory loss will be there according to the level of lesion. And next is anterior cord syndrome. This mainly caused by flexion injuries or vascular origin. And the clinical manifestations like complete loss of motor pain and temperature below the level of injury, but retains proprioception and vibratory sensation. Then the Brown-Sequard syndrome. This mainly is a hemisection of spinal cord. It's mainly caused by penetrating trauma. There will be ipsilateral loss of motor vibratory sensation and proprioception with contralateral loss of pain and temperature sensation. And depends upon the level of injury, the clinical manifestation may vary. Clinical signs and symptoms may vary. The first one is high level of cervical injuries. This is C1 to C4. Most of the patient, this is the most severe form of spinal cord injury. It causes quadriplegia, paralysis of arms, hand, trunk, and legs. Patient may not be able to breathe on his or on cough or control bowel or bladder movements. They may be dependent on the ventilator. Ability to speak is sometimes impaired or reduced, depends on the level of injury. When all 4 limbs are affected, this is called tetraplegia or quadriplegia. Requires complete assistance with activities of daily living, such as eating, dressing, bathing, and getting out in or out of bed. May be able to use powered wheelchairs with the special controls to move around on their own. Requires 24-hour day personal care. Then low cervical nerve injuries. Corresponding nerves controls arms and hands. A person with this level of injury may be able to breathe on their own and speak normally because the phrenic nerve it will be escaped from the injury. So the diaphragm will be they can use the diaphragm muscles. So the phrenic nerve is separated by C3, C4, C5. So this level is below that one. So C5 injury, person can raise his or her arms and hand and bend elbows. Likely to have some or total paralysis of wrist, hand, trunk, and legs. can speak and use diaphragm, but breathing will be weakened because only diaphragm is working, the intercostal and other accessory muscles is weakened. So the forced inspiration and forced expiration will be affected and will need assistance with most activities of daily living, but once in a power wheelchair can move from place to another independently. And C6 nerve injury, nerve affects wrist extension. Paralysis in hands, trunk, and legs typically should be able to bend wrist back. Can speak and use diaphragm, but breathing will be weakened. Can move in and out of wheelchair and bed with assistive equipments. May also be able to drive an adaptive vehicle. C7 injury, nerves control elbow extension and some finger extension. Most can straighten their arms and have normal movement of their shoulders. So once they can use the elbow extension, it will be easy for them to transfer by themselves from wheelchair to bed to wheelchair. Can do most activities of daily living by themselves, but may need assistance with more difficult tasks. May also be able to drive an adapted vehicle. C8 injury, nerves control some hand movement, should be able to grasp and release object, can do most activities of daily living by themselves, but may need assistance with more difficult tasks. May also be able to drive an adapted vehicle. And next we go to thoracic nerves, T1 to T5. Corresponding nerves affect the muscle upper chest and back. Arm and hand function is usually normal. Once T1 is escaped from the injury, then hand function completely escaped from the injury. So there will be having full hand function, upper limb function. Injuries usually affect the trunk and legs, also known as paraplegia. Most likely use a manual wheelchair, can learn to drive a modified car. But these injuries, they will be having problem with sitting balance, mostly because it depends on the level of injury. Upper abdominal muscles and back muscles are affected. So they will be having problem with the sitting balance. They can sit properly with the help of support of hand. Thoracic nerves, T6 to T12. This level of injury, nerves affect muscles of the trunk depending on the level of injury, usually results in paraplegia. Normal upper body movement, fair to good ability to control and balance trunk while in seated position. Should be able to cough productively if abdominal muscles are intact. This also depends on the level of injury. Little or voluntary control of bowel or bladder, but can manage on their own with special equipment, like doing by intermittent catheterization by themselves, they can manage. Most likely use a manual wheelchair, can learn to drive a modified car. Some can stand in standing frame while others may walk with the braces, but this is not a functional ambulation. This is just for a therapeutic ambulation, but it is difficult for them. Lumbar nerves, L1 to L5. Injuries generally result in some loss of function in the hips and legs. Little or no voluntary control of bowel or bladder, but can manage on their own with special equipments. Depending on strength in the legs, may need a wheelchair and may also walk with braces. Then the sacral nerves, S1 to S5. Injuries generally at this level, result in some loss of function in the hips and legs. Little or no voluntary control of bowel or bladder, but can manage on their own with special equipment. Most likely will be able to walk. Next, we are going to talk about complications of spinal cord injury. The main complications, damage to their independence and physical function, and neurogenic bladder and bowel, urinary tract infections, pressure ulcers. Pressure ulcers more common with the high level of spinal cord injuries. Orthostatic hypotension, deep vein thrombosis, fractures, atrophic ossifications, spasticity and contractures, pulmonary and cardiovascular problems, depressive disorders, sexual dysfunction. During the growth period, diabetes and metabolic disease are potentially serious disease in patients who have suffered spinal cord injury in their childhood. Spasticity, insulin resistance, dyslipidemia, reduced glucose transfer, and obesity are common childhood complications. These are the complications, mainly those who have suffered spinal cord injury in their childhood. And another complication, autonomic dysreflexia, is emergency attention needed for this condition. This autonomic dysreflexia, this mostly happens at T6 or higher level of spinal cord injury, triggered by sustained stimuli at T6 or below from this, mostly painful stimuli from restrictive clothing, full bladder or urinary tract infection, from pressure ulcer or pressure areas, fecal impaction. The main symptoms will be like increase in BP, that will be severe and rapid. Patient will be having flushed face or red out. The blood will be rushed into the face. Headache, distended neck veins, decreased heart rate, increased sweating, vasodilatation above level of injury. Vasoconstriction below level of injury, that causes the blood will be pumped up. Patient will be pale if vasoconstriction below level of injury, pale, cool, and nauseating. And treatment and management of spinal cord injury. The functional goals, short and long-term functional charges are determined by the calculation of the patient's ASIA scale, taking into consideration medical and social status and the individualized rehabilitation plan. Expected functions of motor complete injury patients at the end of first year according to the level of injury are given below. So each level there will be expected functional outcome. So that will be reached within the first year of injury. From 1 year, one year, within the 1 year, the first C1 to C4 levels, patient with C3 and higher levels need ventilator support because of the paralysis of diaphragm. C4 level patients can manage spontaneous respiration. This patient in this level are completely dependent. Mouth bars can be used for some activities such as page turning and writing. Wheelchairs must have high back support and safety belt, which is able to stabilize the body and is available for a reclining or tilting position. Battery powered wheelchairs must have a head, tongue, or breath or jaw control. So C5 level, there is enough elbow flexion muscle strength in this level. Range of motion and stretching exercises are more important in the acute stage to prevent elbow flexion and supination contractures. Static positioning of the hand orthosis preserve the more wrist extensors against overstretching. Patient can use a battery powered wheelchair with a joystick modification and can push a manual wheelchair with special gloves. Transferability is completely dependent. C6 level. Active wrist extension is possible and hand grip can be achieved with a tenodesis effect. That is tenodesis grasp. And this tenodesis hand grip grasp achieved by extension of wrist utilizing the passive insufficiency of long flexes of forearm, released by flexion of wrist. The hand grasp will be achieved by extension of the wrist and released by the flexion of the wrist. Those who have finger flexes at C6 level, finger flexes will be weak, so they can use this tenodesis grasp for functional holding water bottles and all. C7, C8 levels. The elbow extension in C7 level and finger flexor muscle strength in C8 level is sufficient. Patients are independent in most daily living activities and transfers. They may need some help in lower extremity dressing. A manual wheelchair is accessible and wheelchair transfer is successful. Specially equipped cars can be used. T1 to T12 levels. Patients are independent in daily living activities, bowel and bladder care, using a manual wheelchair and transferring. Body control is present in lower thoracic injury patients and they may be ambulant at home with lower extremity orthosis and a walker. L1, L2 levels. They are fully independent in activities of daily living and personal care. They may be ambulatory with long leg walking device for short distance, but they need a wheelchair for long distance. L3, L4 levels. Patient can lock the knee fully and dorsiflexion of the ankle can be partly made. Patient can ambulate socially with elbow crutches and ankle foot orthosis. They are independent in bowel and bladder care. L5 and lower, they are independent in all activities of daily living. And next we are going to acute and subacute rehabilitation in spinal cord injury. This period begins with the admission to a hospital and stabilization of patient's neurological state and is 6 to 12 week bed period. The aim of rehabilitation in this period is to prevent complications that may occur long term. Passive exercise should be done intensively to resolve contractures, muscle atrophy, and pain during the acute period of hospitalization in patients with complete injury. Positioning of the joints is important in order to protect the articularly structure and maintain the optimal muscle tone. Sandbags and pillows can be used in positioning. If the pillows and sandbags are not able to provide positioning, it can be achieved with plaster splints or more rigid orthotics. Angle foot orthosis, knee angle foot orthosis, or static angle foot orthosis extra are mainly used for this purpose. Shoulder range of motion exercises are more important to prevent pain in all levels of damage. Passive range of motion exercise should be done for both upper extremities in C1 to C4 level tetraplegia. In injuries of C5 and C6 level, range of motion exercise should be done to prevent the development of contractures, especially contractures of elbow flexion and supination. Stretching should be done to protect the tenosis effect in patient without active wrist extension and fingers that are not fully stretched. Muscles are flaccid during the spinal shock period, so the overstretching we have to avoid to prevent the injury to the muscles. Exercise can be done more easily with flaccid muscles. Flaccidity is replaced with spasticity after the period of spinal shock. Isometric active or active assisted triangle exercise should be done in patient's bed if partial movements are present, depending on the level of injury. Studies have shown that early mobilization plays an important role in prevention of pulmonary function decline and in the development of muscle strength. Breathing exercise should be carried out and taught, and its importance should be explained to complete or incomplete paraplegic and tetraplegic patients during the acute phase in order to protect lung capacity. In order to prevent decubitus ulcer, the patient position should be changed every 2 to 3 hours. Decubitus ulcers occurs most frequently on the sacrum, ischium, trochanter, and superior aspect of the heel. In addition, attention should be paid to keeping the skin clean and preventing the formation of decubitus ulcers. Flexion contractures of the hip may develop due to continuous lying on the side and sitting in the wheelchair. Flexus muscle tension can be reduced with the prone position at regular intervals and range of motion exercise in all directions. Orthostatic hypotension is likely to be found in patients with a long period of lying in bed. Syncope can be seen in these patients while sitting and being lifted up due to low blood pressure. A tilt table may be useful for patients with this condition starting from 45 degrees for 30 minutes a day. The degree increase according to the patient complaints or state. Wheelchairs, walkers, and crutches are used for out-of-bed transferring of patient. The wheelchair is most important tool for spinal cord injury patients to be mobile and participate in social life. Ideally, wheelchair must allow for optimal mobility, protect skin integrity, and maintain the normal anatomical posture. A battery-assisted wheelchair is appropriate for injuries at the upper level or upper segments, where a manual wheelchair is preferred at lower levels. Functional neuromuscular stimulation is based on innervating nerve fibers of intact muscles. If the muscles are denervated, functional nerve stimulation stimulates the muscle fibers. A study suggests that suitable activation to specific muscles of the trunk and lower extremity can enable patients with spinal cord injury to alter their standing postures with minimal upper body effort and subsequently increase the muscle volume. Next is the robotics. Robotics plays an important role in rehabilitation. Robotics in spinal cord injury rehabilitation uses brain and sensory motor interfaces, virtual reality environments, and learning-based gaming programs to maximize independence and quality of life with moderate to severe physical impairments. This is mainly a task and goal-oriented programs, repetitive, progressive, and purposeful programs, fun and interesting and practical programs, provide feedback on accuracy of task completion can be matched to patient abilities. Safe for training, like robotic rehabilitation, that very less chance to fall from gait training, like that kind of training, very less chance of falls. Reliable in performance, we can do repetitive movement for a longer period of time with reliability, able to reduce risk of injury. Rehabilitation robotics includes service robots for movements, service robot for physical assistant and indoor and outdoor navigation, non-wearable robotic assistive device for mobility, unweighing, and object manipulation. wearable robotic assistive devices for upper limb object manipulation, wearable robotic assistive device for lower limb mobility and gait training, communication robotics to enable interpersonal interactions, interactive entertainment robotics for companionship and emotional support. And these are the reference. And thank you everyone for listening.